Hello and welcome to our proposal for reducing a significant clinical issue within the healthcare system witnessed in the video Learning from Error. My name is Freya.
Farzana, Kim, Grace,
Carrington and Keith.
We identified the negative impact of the hierarchical culture between nurses and physicians on effective communication, resulting in incidents, errors that can cause harm to patients as a clinical risk within the film. This is evident through the nurse attempting to convey to Dr. Livingston that Dr. Campbell does not know the protocols of the hospital, therefore it is unsafe for him to be performing procedures without sufficient supervision. The nurse was disregarded, with the doctor executing her hierarchy over the nurse, stating in a passive-aggressive tone that if Dr. Monroe thinks he is competent, he must be. This directly led to Jane being put at risk. This clinical issue involves all members of the healthcare team, including nurses, physicians, staff members and allied health. This aligns with the National Safety and Quality Health Service Standard 6 of Communicating for Safety. It discusses communication of critical information and the risks that emerge if not effectively executed. This standard also outlines how clinical handover, clinical governance and quality improvement can support effective and coordinated communication that delivers safe care for patients. We will address how the breakdown in communication techniques is a significant preventative factor in serious adverse events. Our goal is reducing the number of incidents of error occurring as a result of hierarchical culture, negatively impacting on communication between physicians and nurses. We are measuring through self-satisfaction surveys and reducing the number of incident reports that refer to communication breakdown or interprofessional bullying by 20%. The goal is attainable with time, effort and implementation of appropriate interventions occurring within the healthcare facility. If communication barriers are reduced, this will increase patient safety and reduce the risk of patient harm caused from hierarchical culture. The results of the interventional communication will be tested throughout a year.
Nurses and physicians are the primary carers in the acute setting, so weighing it all found for patients to achieve optimal outcomes and a high level of care without suffering incidents or harm, it requires effective interdisciplinary communication between nursing and physician staff. Hierarchical culture creates a barrier within communication between that of the nursing team and the physicians. This can have a direct negative impact upon patient health outcomes. Tangio and Kelly found that the nurse's expertise on the patient situation and their delivery of holistic information is often impeded by physicians that are unreceptive to it and tend to misinterpret it to be subjective and irrelevant. Exacerbating this breakdown in communication in patient care, Burke, Bowl and Mitchell found some physicians will ignore or decline requests for follow-up or review made by concerned nursing staff, resulting in avoidable deterioration and patient harm, like those found by Burke, Bowl and Mitchell, where ICU admissions have increased as a direct result of communication barriers and poor nurse-physician collaboration due to hierarchical culture. Hierarchical communication impedes nurses' abilities to ensure their patient safety. If Jane's nurses had been allowed to critique the practice of the medical team, the medical error could have been avoided. Reducing the amount of adverse health outcomes resulting from poor communication could be achieved in two ways. Implementing intraprofessional standardised ISBAR communication to clearly and effectively communicate the patient's identity, situation, background assessments and clinical recommendations to physicians, and through supporting interdisciplinary communication and cooperation through clinical leadership and governance initiatives like group training and protocol development to improve professional relationships and standards. Improvement could be measured subjectively through professional relationship satisfaction surveys and objectively by observing a reduction in the number of incidents reports relating to patient safety and harm that report communication breakdown due to hierarchical culture as the cause of incident. ISBAR provides a structured format applicable to all health professionals, limiting the impact of hierarchical culture on effective communication of the patient's situation to improve patient outcomes and avoid unnecessary harm. In clinical leadership and governance, in implementing protocols and interdisciplinary group training of nursing and physician staff can improve professional relationships and standards.
Martins et al. Have identified PDSA cycle as an effective tool in analyzing the effectiveness of open communication and tools such as ISBAR in enhancing patient safety and preventing errors. The plan is to conduct anonymous cross-sectional surveys of different multidisciplinary groups about speaking up, then analyzing the data collected from surveys and implement management strategies that can contribute towards patient safety. The changes that will result in improvement are creating a safe environment where everyone respects each other's role, team training, communication tools such as ISBAR or checklists, posters such as national standards should be displayed around healthcare setting. In their research, Roa, Carvalho and Cummings identified that adherence of organizational policies, protocols and procedures through effective leadership improves quality of care and patient safety. Developing programs or training sessions where staff can safely practice their skills that enhances their learnings. This would also help interdisciplinary multidisciplinary professionals gain a mutual respect for each other. Based on comparing, analyzing, and summarizing a yearly outcome to the previous year, the changes that contribute in the improvements are leaders should make sure that organize training sessions and encourage staff to participate. Leaders should ensure that staff follow up organizational policies and procedures. Leaders support individuals who arise concerns about colleagues' competency and safety of delivering care.
Following the development of a PDSA cycle for decreased impact of hierarchy on communication, introduction of ISBAR handover in the clinical environment can occur. Spooner et al. States that the provision of structured education training on the purpose and importance of ISBAR and how to use such can improve clinical communication in handover. The introduction of this within the clinical environment creates a standardized and interprofessionally used method of communication. If ISBAR was implemented in the scenario, the miscommunication that led to the overall error of the intrathecal injection could have been reduced, in turn improving patient safety. Tan, Zhao, and Kelly suggest use of communication checklists in order to improve information handover. The author then states that the effects of such implementation assist in eliminating confusion related to differing communication styles that professionals use. The Victorian Health Incident Management Policy Guide suggests that the efficacy of the intervention can be measured through staff surveys of communication through the clinical hierarchy, as well as reviewing past and future incident reports, comparing the number of communication errors in such. Regular conductions of these comparative reviews allows for adjustments and improvements to occur to the proposed intervention. Moreover, implementation of clinical leadership and governance would increase patient safety by reducing hierarchical discomfort for staff when communicating with team members. Roa, Carbello, and Cummings suggest that the introductions through team education sessions allows for improved leadership within such roles through increased knowledge of safety protocols and interventions. As a result of improved team relationships, Harrison et al. Suggests an increase in effective escalation of concerns, and the resulting implementation of protocol is present. The presence of clinical leadership within the scenario would have prevented the task being completed without the presence of a team environment or the following of protocol. Measurement of efficiency could occur through staff surveys surrounding confidence and escalating concerns to leaders. Zasmarati, Sassali, and Amadi suggest the analysis of past events through investigation of incident reports to identify where the error occurred, as well as regular reviews and comparison of the amount of ICU admissions as a result of communication breakdowns, providing objective data to create a trend on whether the intervention is effective.
The spread framework which mentioned in the Improvement Guidebook published in 2009 will be used to measure and evaluate system performance. The idea that ISBAR in clinical handover ensure accuracy and adequacy of patient information delivered through standardizing interprofessional communication and eliminating confusion caused by different communication styles. Also, providing patient-central care is correlated to the quality of handover conducted. The aim is to minimize risk as handover, which is the core principle in Australian Safety and Quality Framework for Healthcare and National Standard. Target population staff who are working in ICU target frame a year 3 target levels of system performance. Magnus Perry 2017 suggests that good handover practice will be noted and reinforced as training the decrease in communication errors related to handover information. The increase in frequency of using ISBAR in practice reporting can be done through encouraging peer report of substandard handover, poor and toxic communication, staff survey, and evaluating regarding to the application of ISBAR practice. In the anonymous article 2016 suggests that applying peer messenger trend to raise awareness and self-reflection would report individuals in the private and non-judgmental conversation. The improvement can be using root cause analysis for investigation any errors related to ISBAR practice. Risk-based PDSA cycle should be applied when error occurs. Review and updating the ISBAR practice in general staff meeting. The idea of rest on nursing leadership is foundational to quality improvement, and it refers to transformation leadership principles. Target population will be staff who are working in the ICU. Target system performance are that effective communication and active listening should be promoted in nursing leadership, and staff is aware of the importance of leadership in delivering continuous safe care through training or organizational policy. Reporting can be viewed in evaluating staff satisfaction measurement regarding the leadership and evaluation through the efficiency of work performance. The improvement can be marked in quality report of current projects PDSA cycle if necessary.
In the video Learning from Error, one of the contributing factors to Jane's adverse health outcome was the hierarchical nature of interprofessional communication. In this video, we have outlined interventions to avoid these events in the future. These included the implementation of ISBAR communication in the hospital and the development of interprofessional training programs to build bridges and respect amongst members of the healthcare team. Thank you for taking the time to watch this video, and we hoped you enjoyed watching it as much as we did making it. Sound check.
I had bad timing.